great to be here this morning. Everyone's had coffee, they've had fresh air. It's going to be very enthusiastic, I can tell. It's going to be really enthusiastic, I can tell. Fantastic. That was much better. Let's keep that up for the next hour. I would like to have our whole panel just kind of all come up and sit down together if we can as we get started. Again, I am pleased to be your moderator this morning. Michelle Winokur, the Chief Executive of the International Atherosclerosis Society. And as the panelists are taking their seats, I'm going to introduce each of them. Taskeen Khan is the Director of Research and Policy at the Qatari Foundation and also a member of the WHF Advocacy Committee. We have Professor Bruce Neal, the Executive Director of the George Institute for Global Health based in Australia. Dr. Shriram, I was close. Aradier, the President and Development and Chief Medical Officer of Novartis, and Dr. Rick Shazel, Senior Cardiologist and Medical Director for Quality Transformation and Innovation at Lee Health. At least I tried. Rick is at Lee Health Heart Systems in Fort Myers, Florida, and is also the WHF Board Treasurer for this term. We have Gemma Figtree, a professor of medicine from Sydney, Australia, and Jose Ramon Wanate, who's the head of cardiology service and CCU at the University Clinical Hospital and professor of cardiology at the University of Santiago de Compostela in Spain, and another WHF board member. So we have a really distinguished panel this morning. And before we dive into conversation with all of these panelists, I would like to invite our pace setter lecturer. All right. Perfect. With no introduction, because he's already standing behind me, I will turn over the mic for 15 minutes to get us kicked off with our pace setter for this lovely panel. Thank you so much.
Why don't you say that the name is even more difficult than Sri Rama?
Yeah.
Doraj. Dr. Doraj.
Okay, right. Thank you. So good morning once again, and you just had a flavor of what I'm going to say in my panel discussion earlier on. So in the next 15 minutes, I'm just going to talk about, discuss some of the aspects of multimorbidity in the context of cardiovascular disease, and what are the challenges that we face in most parts of the world, and what can we do about it. So these are the three questions that I'm going to address. So let us see how a typical patient of NCD looks like in the current context. So this is a patient who was 65 years old and a non-smoker, was admitted with high fever and cough of 3 days duration. A COVID test was done which was negative. She was referred to a family physician for admission as the SpO2 was 90% or 91% and respiratory rate was very high. She was diagnosed with diabetes 15 years back, was on an oral hypoglycemic drug. She underwent PCI with 2 stents in the LAD and RCA for acute coronary syndrome 2 years back. Other significant finding was that her BMI was 28, serum creatinine was 2 milligrams per deciliter. She had mild sensorineural hearing loss. She deteriorated rapidly and died within 24 hours of admission, despite aggressive treatment including ventilatory support. What is the cause of death listed? They said she had ARDS with pneumonia, septicemic shock, and the culture that came later on said that she had influenza infection. So, is this the real cause? This is the question that we pose. This may be the most proximate biological cause, but what are the other things which led to this path of death? She was told by the endocrinologist that she should take annual flu shots along with pneumococcal vaccine. Her cardiologist felt that it did not make a difference. It would not make a difference. She had also learned from her friends and social media that vaccines cause more harm than good. She herself was educated till the 8th grade. There was no social insurance. The bronchial aspirate, as I said earlier, identified influenza A, and culture was awaited. So what actually caused her death? Number one, it was multimorbidity. Look at the number of conditions that she had. She had diabetes, cardiovascular disease, mild renal disease, query potential dementia, because hearing loss is the most important risk factor for dementia, which we don't really recognize. There was poor access to care, poor education and poor socioeconomic status, fragmented healthcare. You saw that she went to multiple specialists, lack of integrated care, confusing messages, particularly by the social media, and people are totally confused, and even doctors confuse patients. Then social determinants, we don't know. She was living in the city of Delhi. Did air pollution actually accentuate? At that month in November, we have PM 2.5 values of 300 to 400. So did that actually pose additional problems? And there may be several others. So given this background, let's look at what are multiple long-term conditions or multimorbidity. So multimorbidity or multiple long-term condition is the co-occurrence of two or more chronic conditions, and it is emerging as a public health problem globally and in many low-middle income countries. People with multiple long-term conditions are more prone to rapid decline in physical and mental health, disability, decreased quality of life, early and high mortality, higher healthcare utilization and costs, whereas comorbidity is a condition which, for example, there are additional conditions in reference to the index chronic condition. So it could be just a complication of that particular condition. The problem of the understanding is both are rooted in biology, and we ignore several other factors that influence response to disease. So let's look at some of those factors that influence the multimorbidity. And I think here what is important for us to understand is there are several other factors which influence how a person responds to a disease. And syndemics represent the convergence of two or more health conditions, often infectious diseases and NCDs, which interact synergistically to worsen health outcomes and increase the overall disease burden. And therefore, understanding syndemics helps public health professionals and researchers to develop effective strategies for preventing these diseases. And to this mix, we also need to add climate change, particularly heat, extreme heat and extreme cold, or sudden changes in temperature, both cold and heat, can increase the risk of both infectious diseases and NCDs. So we need some resilience to climate change. The next question that I pose is, why should we focus on multimorbidity? The phenotype of the population has changed from 1980s till now. In 1980s, you would get away with having a single disease. There is a person of hypertension, you would treat that person. But now they have multiple problems together. And there is a changing paradigm of healthcare now. Earlier, we focused on reducing mortality. Now we have conquered mortality in many parts of the world in terms of treating diseases. But the quality of life is poor. The health-adjusted life expectancy is lower. You may have life expectancy of 85, 86 years, whereas health-adjusted life expectancy is just around 65 years or so. So 20 years people may be living in ill health, and we need to do something about it. The second is the complications of many of these diseases overlap and affect quality of life for people living with overweight or obesity. For example, I'm giving obesity as an example here. People living with overweight or obesity have type 2 diabetes, have cardiovascular disease, have chronic kidney disease, have metabolically associated liver disease, and metabolically associated steatotic hepatitis. Apart from that, you see the prevalence of the burden of the disease across the world. They are rising. We saw hypertension is 50% in the US in the presentation by Dr. Narula in the morning, but it is true of many parts of the world. In urban India, it is 50%. In Africa, it's close to 30, 40%. So it's huge burden, and therefore, we need to do something about it. The second thing that we need to do is we need to move away from one patient, one condition, and that's how we have been taught medicine. And we need to think of people as a whole and not as in a reductionist paradigm. Take the example of ischemic heart disease. It is the commonest cause of death in type 2 diabetes. It is the commonest cause of death in chronic kidney disease. Intervention is risky in patients with chronic kidney disease. And the cardiovascular benefit comes quite a bit from an anti-diabetic drug. So you can look at the various interactions, the various aspects of the disease together. Now, what about MLTCs or multiple long-term conditions in low middle income countries? There's very limited epidemiological research. There are, because of inconsistent definitions, limited data on common clusters, incidence, and economic impact, limited implementation research on care gaps, lack of integrated programs, and current programs such as the program in India And the WHO PEN package, for example, largely address chronic diseases individually, and we need to think of addressing them collectively. And there are no national programs anywhere in the world to address MLTCs. So what are the barriers to management? And there are several barriers, the most important of which is the fragmentation of health and social care, limited resources, workforce issues. There is a huge shortage of trained physicians, forget the specialists, trained physicians in many parts of the world, and even nurses. So how do we improve the workforce shortage? Sustainability, you may have a good program which may work in pilots, but how do you sustain them? How do you scale them up? There are geographic barriers. Socioeconomic factors, health literacy is a problem, digital divide, we're talking about digital technologies which are very helpful, but there's a huge digital divide which causes enormous amounts of inequities. Compliance and for sustained behavior change and adherence, we have the World Adherence Day, we all know how adherence is poor. So let me give you some examples of the research that we do in India's exemplars of potential solutions for managing MLTCs. And we have been talking in the morning, and Dr. Reddy also mentioned team-based care. So the 4 solutions that are possible in terms of MLTCs are team-based care, team-based integrated care, care coordination, use of frugal technologies, and how can we simplify this in the context of LMICs? These are the 4 questions that we need to ask. The first question is about care coordination. Does it help? So we did a large meta-analysis of looking at management of hypertension, diabetes, and lipids using a care coordination pathway with a variety of healthcare workers. This is an example of hypertension, and what we found was any healthcare worker, any non-physician healthcare worker can assist in care coordination of the management of hypertension. It can reduce on an average blood pressure by around 5 millimeters of mercury. But there were some heterogeneity that community health workers performed well with simple interventions. But the question that we asked again was, can we enhance community health worker performance by pairing them with simple technology? And one of the simple technologies that is available to us is the clinical decision support system. So what is a clinical decision support system? They're computer-based algorithms that analyze data within the electronic health record to provide prompts and reminders to assist healthcare providers in implementing evidence-based management. And so they actually give a personalized management plan for the patients. And they have enormous benefits. And in fact, the CDC US has suggested that it's one of the most important advances in the management of multiple diseases. And McKinsey says that you could save billions of dollars over a 20-year period if we try and incorporate clinical decision support systems. But this requires health system redesign. We were talking about health system redesign in the morning. What happens now in current health system is a patient comes to a hospital, goes to the billing center, and then she's referred to a doctor. The doctor refers to another specialist, and then it goes on, and they take 2-3 days to come up with a solution. So we decided that there should be a nurse who should be trained to handle a clinical decision support system. In India, none other than a physician can prescribe drugs, and therefore we created a system where the nurse would print out the output of the clinical decision support, send it to the doctor could agree or disagree with the management, and then the patient comes back and receives the lifestyle advice from the nurse. And let me show you some of the results that we have. This was a trial using this mechanism which was conducted in tertiary care centers, and you look at when all the decision support system prompts were accepted, how better it was in terms of control, for example, for hemoglobin A1C, systolic blood pressure, or LDL cholesterol. Now, what we did this was because one swallow does not make a summer, we had to test this across the health system. So we worked in the communities, primary health care, secondary health care, showed by differing mechanisms that it worked across the board. And then we scaled it up in 2 states of India. Now it's part of the national program. This is an example of how you're trying to translate science into policy. And this is a 15-year effort to get to this. The next thing about this is this still has the patient, you need the patient to come to the clinic, but can you improve access? In Tamil Nadu, there is a movement called Makkalai Thedi Maruthuvam, which means home-based healthcare, that you're going in search of patients to the home. So you identify patients with hypertension, diabetes, and give care at their homes. But how do you connect them to a specialist? So we created an interoperable platform called DigiSetu, which means digital bridge. So it has the electronic decision support, it has point-of-care devices which can do multiple blood tests, it has a portable echo. My friend Karthik is here who's going to provide this to us. Then we have ABDM, which is digital platform compliant platform of the government. We have digital ophthalmoscope, an AI-enabled ECG, and an electronic stethoscope. And now, through this, you can provide care in a designated telemedicine center, or a health worker can take this, because it's just around 2 kgs, can take this and go to the houses of the patients and provide care. Or you can put it in a mobile clinic and provide care where the patients are, because they don't come. So we have envisaged in a large cluster randomized trial of this platform to provide CVD care for the elderly in 48 clusters across the country. So this will begin soon. But I'm just going to give a snapshot of what happened in 2 clinics in Tamil Nadu where we did this program. We touched within 2 years more than 100,000 people, but the most important was the time and cost saved for these patients. It just took 45 minutes for them to consult a specialist. And then they also had linkage to e-pharmacy so that they can get their drugs delivered at home. And the cost saved was almost 1,000 rupees. And you can see here in terms of the clinical outcomes. So even the benefits of this hypertension control or treatment to targets persisted till 18 months. So this is quite a powerful tool in terms of reimagining the health system. So I mentioned reimagining the health system. We require large system transformation to improve care of people living with multiple long-term conditions. We said, instead of having non-physician healthcare provider, can we train patients, enlighten patients, because they have a skin in the game and they know the whole process. And so we are embarking on a very large randomized controlled trial in 100 primary care centers across India and Nepal by training patients who become community champions and providing continuum of care to these patients. Finally, it's not only about science, it's about politics. We need to create a movement. And so we have adopted 6 medical colleges, and we are training medical students and empowering these rural health training centers. We call this Rahat, which in Hindi means relaxation. It's essentially for rural healthcare transformation. And what we are doing is several things. We are doing several interventions at the level of the institution, several interventions at the facility level, and several interventions at the community level. For the first time, we are training community to use digital health. And so these are the kind of pilots that are required if you have to tackle multiple long-term conditions. So I'll stop here and thank you. My mentor, Professor Reddy, likes to say that science is very reductionist, but our solutions have to be holistic. Thank you very much.
Professor Dovairaj, thank you for those opening remarks and really framing our conversation this morning. I particularly like that you started with a case study, a case example, reminding us that patients are at the heart of our conversation and what we should be doing here and thinking about today. So as we know, multimorbidity is becoming a prominent and increasing and prominent challenge in the global healthcare environment, particularly in the context of CVD. Obviously, Jagat's slides this morning shows us this is a front page issue and one that is certainly worthy of our conversation this morning. So I'm excited to be here with all of you and lead us through some conversation around perhaps identification of the issue, some of our key barriers, and hopefully discuss a couple of solutions and where we can go from here to move forward. So with this backdrop, I would like to start with you, Rick. Thinking about, from your perspective, what are some of the most concerning trends in the prevalence of multimorbidity in cardiovascular disease patients? And are there specific combinations of CVDs that we should be most concerned about or being most, giving most of our attention to make the biggest impact in this area?
Well, we've all witnessed the escalation of a lot of problems, some of them new, for example, newly identified, for example, the air pollution problem. But the one that I think deserves focus that impacts so many other risk factors is the terrible problem with obesity and the rise in obesity nationwide, not just nationwide, but worldwide. Started, for example, in the developed countries, but now in the low and middle income countries. And if one thinks about it, this is really a prime example of multifactorial risk because it influences the risk of diabetes, the risk of hypertension, so many other elements. And it also is a good example of something where there can be a combination of both personal impact on the risk of that risk factor, how much I eat, what I eat, but also community and social impacts, taxation on certain types of foods or supplements that may increase weight. So I think this is really perhaps one of the things that's most alarming when you look at the trends. Obesity goes up, hypertension goes up, diabetes goes up, and it's something that we actually probably could change. We could change it at the family level with education. We can change it at the community level with regard to exercise and education. And we can change it at the advocacy level of trying to encourage our governments to promote more healthy eating and perhaps by taxation, using the examples of what we've done with tobacco worldwide, decrease the high-calorie, poor nutritional value foods.
Thank you, thank you. And obviously that varies very broadly for around the world, thinking about the different socioeconomic environments, cultures. But obesity is certainly a prime issue to be concerned about. Tuskegee, I want to come to you next. In your experience thinking about multimorbidity, how does this contribute to the increasing burden on healthcare systems? And maybe can you comment again how that would change across the different socioeconomic statuses of a particular country or region?
Thank you, Michelle. Absolutely. You know, the thing is, I always go back to the fact that health systems were made for acute diseases ideally, particularly public health systems. And so I'm South African, and I can honestly speak to, I like the fact that you mentioned, Dr. Doiraj, about infectious diseases. Because at the end of the day, the problem is that there's a lot of different priorities. And if you go a little step back, in terms of the way national governments are set, health is often the weakest ministry. You know, when you look at it, finance, defense, even sports in my setting is particularly more important. But I think the fact that increasingly people are becoming aware that it's not just about disease. And I like the idea about rethinking the health system because that's exactly what needs to be done. There's so much of fragmentation in care, and particularly in low and middle income settings, but certainly in high income settings as well. The truth is that most countries don't have it right. That there's this very elitist private system, and then there's a public system, and they often don't talk to each other even to be able to get information transferred. So I think that there needs to be a system overhaul, in my opinion. And there also needs to be a bit of trust building. In a lot of places, the community doesn't trust in the public health system. And so they would rather go to specialists for their care. That idea of primary care still hasn't impacted the developing world entirely. The shock and the thought of seeing a nurse, for example, for care still exists. And I think we need to be cognizant of all these factors. At the same time, the patient, as you said, is the heart of everything. But we also can't see it in isolation. There will always be, you know, financial issues. There will always be resource issues. There will always be turf issues, unfortunately. This is where we are. The thing is to move past that, to think past that. And I tend to think that you've got to start somewhere. You can't do everything all at the same time. And I'll end with saying that I am so happy that you presented about the digital solutions. For a long time, I haven't been able to comprehend how apps or new technologies or all this craze around digital health would work. But seeing it and seeing an example has changed my opinion. Thank you very much.
Thank you for that comment. And I think the digital options and digital tools potentially are a great solution for us, depending on how they're implemented. So I want to bounce back to Rick real quick for one more question about healthcare systems. Thinking about the increasing burden of multimorbidity and the increasing prevalence of patients with multiple chronic conditions, how can health systems do better to prepare? What can they do? Can they use these digital tools? And I mean, how are they supposed to be kind of on the front line of this huge issue?
I love what she just said, because the concept of reworking, because our systems, my system, is designed around acute care and treating disease. It is not designed around the prevention of disease. And I think fundamentally what all of us have to do is go back to our own countries, systems, health systems and departments, and try and migrate more toward the prevention piece. And that's going to be the key, because right now what we're doing is not working.
I think you've read my next question. Coming over to Gemma for this one, and really it's talking about primary prevention and early diagnosis, right? If we can get in on some of the front end of this, we don't have to ask our health systems how they're going to respond and how they're going to manage on the back end. So from your perspective, what can we do to prevent some of these, expensive, catastrophic outcomes using early diagnosis and screening tools, and what capacity do we have there?
Yeah, thank you very much for the question. I mean, I'm an interventional cardiologist, and obviously that catastrophic endpoint is what we do, in the middle of the night. But I spend most of the rest of my time trying to figure out how could we avoid this. And I think in addition to trying to actually address the individual, components of this, I'm really kind of influenced by what I see in patients who had a heart attack, 10 years ago, and for some reason they're back in my cath lab, having had suspicious chest pain, and you look at their arteries. And these are people in a well-off environment who've had fantastic management of their other comorbidities, and their coronary disease is actually stable or in fact regressed. So that we get fantastic treatment to people in well-off environments where we're treating these comorbidities well, but how do we actually get the treatment of that atherosclerosis early in individuals that are in less equipped circumstances? So the other area of my work is actually done in Western New South Wales, which is, for an individual to actually get cardiac testing, it was a 1,000-kilometre return trip. And obviously lots of comorbidity with Indigenous Australians, with a high burden of diabetes and chronic kidney disease in particular. And I think one of the things that we've seen really have an impact here, which I think ties in with the recent Lancet Commission for Rethinking Coronary Artery Disease, is the early detection of coronary disease in these high-risk populations. It's something we're seeing the well-off businessman in regular cities taking themselves for CT scans, but we actually now are being kind of, now we can treat the coronary disease. How do we get equitable access of individuals around the world with these high-risk comorbidities to have screening for the actual treatable disease before the catastrophic endpoint? And we need to develop the clinical pathways to do this, but the health and economic opportunity of this is absolutely fantastic. And we actually have recently seen the benefits of working with a CT in the back of a truck, actually providing these services to rural and remote Australians. And when they can visualise their disease at a subclinical level, that actually does lead to treatment of the disease. And you might say, well, how does that differ from someone that already had high cholesterol and diabetes that you're obviously going to try to treat? The treatment goals to achieve remission of coronary disease, which you can do before a heart attack, is very different to the treatment goals at a kind of population level to keep that individual healthy and reduce their probability of developing a disease. So we've actually, try to think about it in a three-step process, but make sure that we're obviously treating the risk factors, but also now moving towards an opportunity to treat coronary artery disease as the biggest killer in these individuals, and something that if we get early, we could actually achieve massive differences in heart attack outcomes, I believe. So I think with the call from the Lancet's Commission and the editorial that Jagat and his team actually wrote around this, I think as WHF we need to start thinking how we're going to implement this at a global level. So that's my experience, and hopefully it's a little provocative, I know, but I think that's a contribution that we can actually make in addition to the risk factor and disease treatment.
No, I think it's an excellent point, and I think it's refreshing to hear someone who focuses more on interventional talk about the value of prevention. I think it's really, really important on the front end. And Jose, I'm coming to you with this next question, thinking about the opportunities we have across healthcare provider groups. How do we get out of silos, not just from the treatment standpoint, but from a prevention standpoint? You know, when a patient presents and they have a condition that isn't necessarily your specific specialty, how are we dealing with them, and how are we working across silos and other healthcare provider groups to really treat patients with comorbid conditions in a more holistic way?
So thank you, Michelle. First of all, when I'm talking about patients, we are talking patients with multimorbidity of cardiovascular patients, we have to be focused on how, first of all, your patients have access to a health system at your local area. It's needed to think at local level and what to do for a particular local area. The patients can be accessed to a health system, public health system, private health system. And that the idea that is we need universal access to the cardiovascular health. And is this possible in your particular area? What to do for improving the accessibility? This is the first, because we can talk about globally and global approaches and how to reduce the impact of factors that increase the cardiovascular risk. But when you are talking about patients, you have to think how to screen, clinical evaluation, how to treat, how to follow, but at local level, because the patients are your local level, and you have to do things for improving the accessibility. Then you have also to work in a integrated, multidisciplinary manner. In the great majority of in my area, all the patients, all the individuals have a GP in Inchap, and an RCGP, but it's probably not the case in many, many other places. So you have to develop what is the best you can do at your local area for screening, evaluate, and treat the patients, and also include some quality markers if you are doing the right thing. For example, when you are talking about guidelines, recommendations, you have to move from evidence science to implementation science. It is possible to implement at your local area the guideline recommendations. How you can implement, not only on the high-income individuals, how educated individuals. Recently was published that in the United States, the life expectancy barriers more than 10 years between low socioeconomical individuals and high socioeconomical individuals. And most of the difference is based on cardiovascular mortality. So it's needed to think when talking about patients on local solutions, and also how to develop, to implement. In Spain, it's easy to say because it's a universal coverage, it's a well-developed public health system, probably it's the best social improvement in my country. But we have to maintain a high-quality public health system. If you suffer whatever heavy condition in my country, please go to a public hospital, no a private hospital, because it's much better. The quality would be much better. But it's needed to translate this mode of thinking globally, but at local areas. And obviously, we have to implement new tools, because face-to-face, as the classical mode to implement the science, probably we have new tools like digital transformation, how to interconnect health professionals, for example, with an integrated electronic medical record among nurses, GPs, hospital specialists. So at the end, when you are talking about patients, you need to thinking locally and how we implement the access to the care at local level. I think this is, for me, the great message, because you need to think how to implement not only in the privileged people, but also in all the people the care, and in this case, the multimorbidity, because when you are talking about multimorbidity, you are talking about patients. You have to identify, to treat, to follow the patients, but you need solutions at your local area.
I really like that. I like your comment about using technology as well. And I think I want to just follow up with you on one thing you said about thinking about how we can expand the workforce and really use more provider types to help with addressing this issue, right? We can't have every issue be solved by a specialist. It's just not feasible. Leaning into nurses and community health workers. Is there any examples that you can share about a tool or a broader group of healthcare providers that would be a good case example to share here?
Yeah, for example, since several years, we implement at our autonomous regions, that is nearly 3 million people, we have an integrated electronic medical record. All the Galician people, all the health data are in a unique integrated electronic and medical record since 20 years ago. It is really impressive. And this could do new tools implementation like e-consultations. For example, we receive more than 8,000 referrals from GP to our cardiology departments. All the reference first, all of them are through electronic medical record, which is the reason for the referral, some tests like ECG, lab, whatever the patient needs. And then a cardiology review the request in less than 3 days, and then decide, can solve the request. We solve around 40% of the request without a face-to-face appointment. And if the patient needs a face-to-face appointment, you know the risk of the patient. You can schedule a visit the day after, or always in less than 40 days. This program, first of all, improves the accessibility to care, because when all the patients came to our university hospital, the rate of referrals were higher in the health centers closer to the hospital and much lower in the faraway centers. When we implement this e-consultation program, the rates of e-consultation was exactly the same. Far away, this was a circulation publication. This tool improved the accessibility, but not only improved the accessibility of the more vulnerable people, older people living high distances from the hospital, but also improve the outcomes, because you reduce the waiting time for be solved, the request, and you see a marked reduction in the need for emergency department visit. We describe a reduction in the need of hospitalizations, and we describe a reduction in mortality. So it's needed to thinking at local level, it's needed to develop health technologies, digital health technologies. Is the second priority in the European Cardiovascular Plan, how to develop digital health technologies for improving cardiovascular health. And then you have to thinking at local level for improve the accessibility and for improve the outcomes of the patients.
Yeah, no, absolutely, absolutely. And I think to your point, really we need to make sure we're thinking about multiple solutions, right? There's not going to be one single way to tackle this issue of multimorbidity. We need to think about crafting good public policy. We need to improve our physical environments. We need to use innovative medications as they become available. And there's another factor that I want to come over to you, Bruce, next to discuss that we can work toward improving is food quality and supply. So can you give a little bit of a comment on how can we see changes in food supply contribute to the management of multimorbidity, and how can we use food as medicine in that way?
Yeah, thanks, Michelle. I should say, it's very refreshing to be sitting in a meeting about multimorbidity and to have heard almost everyone talk about prevention, not just about the sort of the diseases that the patient has and the clinical response to them, because it's understandably very easy to focus on that, because that is what presents to the health system and what needs managing. But if we think upstream, then there are 3 or 4 or 5 big risks that are causing most cardiovascular disease. And if we think, for example, about tobacco, then tobacco is causing not just ischemic heart disease, but it's clearly a really important cause of stroke, peripheral artery disease, heart failure, etc. And beyond that, tobacco, of course, is a major cause of cancers and respiratory diseases. So it really is a massive cause of multimorbidity. Now, tobacco, as we heard when Srinath spoke, affects about 1.3 billion people, I think. When we turn to food, food affects probably 8.1 billion. It affects pretty much everyone in the world because almost everyone eats a diet that is suboptimal in some way. And if you look at the global burden of disease metrics, you find that probably a third or more of all premature death, disability, and multimorbidity is actually attributable in some way to a poor diet. So I think it's great that we've got this new focus on multimorbidity. I think it's great that we're thinking about how do we do better in the clinical setting, but let's use this as an opportunity to also think how can we do better in prevention. And obviously there are a few success stories in prevention, but mostly there's a whole lot of failures. So I think we've seen some countries do really well in tobacco control. There are very few countries that have done well in terms of food and food system type interventions. So what I would like to see us do and to think about is how can we use this as an opportunity to reinvigorate research and implementation and evaluation within the food system as a way of addressing multimorbidity, which is such a pressing issue for all of us.
That's a fantastic answer. Thank you, Bruce. I have one more sort of food-related question for you, if I can. You have been very involved in a long-standing effort to switch the world's salt supply, which obviously affects our food and how we consume and what we consume. Can you talk about that movement briefly and give some background and why it's relevant to today's conversation?
Yeah, thanks. I love being given an opportunity to talk about my favorite topic, so thanks very much, Michelle. I've, with many colleagues around the world, with the World Health Organization, have worked on trying to cut sodium intake around the world for 20 years or more. And to be completely honest, have mostly failed. Because it turns out that it's really hard to get people to accept a less salty taste, which is what happens if you take salt out of food. And it also turns out to be really hard to persuade people to add less salt to food when they're cooking, whether that's in the home or indeed if you're a food manufacturer. So we and others around the world have recognized that this challenge, again, for many years, and identified an alternate strategy, which is to move from trying to cut to trying to switch. And basically what that means is instead of putting 100% sodium chloride into your food when you season your food or you make your recipes, put in a product which has got some of the sodium chloride, and in the case of the big studies we've done, 25% of the sodium chloride replaced with potassium chloride. Now, at that level, most people can't taste a difference, and you can use it as a direct one-for-one switch. And we think this actually might be a tractable proposition. The world has changed its salt supply once before, from regular salt to iodized salt, and that is widely recognized as a massive global public health success. And we think there's probably a huge opportunity to make the next switch from iodized salt to iodized and potassium-enriched salt. And we'll release some data around what we think the potential impact is, but it looks pretty enormous because everyone eats way more salt than they did during hominid evolution. During hominid evolution, we ate about 0.5 gram of sodium a day. We now, on average, eat about 4 grams a day, so massively more. And with that massive excess becomes massive opportunity. So I think a really exciting sort of opportunity, and again, huge potential for benefits for multimorbidity because salt causes high blood pressure, which underpins almost every vascular disease, but salt probably also is a major cause of gastric cancer too.
Interesting. Thank you, Bruce. And that'd be a huge system change, right? Thinking about the way food is manufactured, not just how we kind of shake it onto our table every night, right? But I want to go from kind of this big idea of sort of a big system environmental change, coming back to Taskeen for a minute to ask you about some patient-specific changes, thinking about how do we empower patients to take a more active role in managing their health when they're dealing with multiple comorbid conditions? What can we ask them to do in the face of not having a patient on this panel? What would we expect a patient to say in this chance, and how can we encourage them and be more supportive?
So I think when it comes to patients, it's important to recognize that health literacy is quite poor. I think communication in general from the scientific community is also quite poor. Unfortunately, most of our patients don't know, and this is a personal story, a patient who had been at a clinic for at least 10 years said that no one had explained to her that her high blood pressure would either cause heart attack or stroke. And so she never bothered to take the medication because she didn't really see it as an issue. You know, she was walking around fine, everything felt fine, and there was really no need for her to actually take the meds. And that I was the first person to actually tell her that there was some link to something, and that's why she should actually be taking the medication. So I'm certainly not alone. There are tons of patients who don't understand. But I also think that that is just one side in the system, because I think that, you know, we cannot expect, and I'm quite against the idea of the physician doing counseling at an individual level to lead to behavior change. I think you articulated it very well, Bruce. We failed. It's not a, you know, it's not a reasonable intervention. I mean, I can't convince my 5-year-old to wear a jacket when it's freezing outside, but, you know, really hot inside. So that's just an idea of the, you know, the level of behavior change. But I do think that better literacy needs to be out there, and that if better literacy is communicated in the right way, patients will automatically feel empowered, and they will automatically get together, whether you provide them with a place, for example, in the clinic or outside the clinic preferably. They will come together and congregate once better informed. Thank you.
Thank you. Gemma, did you have something to add to that?
I was just going to follow on. I mean, I think what you said is absolutely right, but listening to the patient about what their priority is really important. And one of the things that I find, you know, particularly relevant to some people is not necessarily heart attack prevention, because a lot of people say, oh, actually, that's a great way to go. I don't know what to say when that's the case, because I'm not so sure it's that great. But I think things like the association with a lot of the comorbidities with dementia is actually very powerful in terms of actually trying to help drive people's efforts at a healthier life, and stroke, absolutely. So I think listening to the patient and actually trying to see what drives their health is really important. And then I think the other thing is really trying to understand the tendency for community and patients to feel a sense of blame and shame around cardiovascular disease. And so one of the challenges with risk factors being associated with the disease is, you know, many of these are lifestyle based, and people feel like, you know, they're a bit embarrassed about this, and this is something that they've done to themselves, when in fact we've got to put a positive spin on this and really look at how we have huge variation. I mean, the same risk factors drive many cancers, and yet we don't blame the patient. And so I think understanding that shame and blame side of things is really important. And again, back to the fact that there's this variation in susceptibility to the actual complications of the comorbidity, that's biological. A bit like with obesity, we now understand obesity is not all self-induced. This is actually a biological thing. And so trying to take it away from that individual's, you know, what they've done to themselves to actually something that they have now the opportunity to try to avoid. So that's my comment.
Thank you for that, and I agree. I think shame is incredibly unhelpful, but empowerment certainly is. And Shram, you waited so patiently for me to come down to you. Wanted to ask you, thinking about patient empowerment and using patients, involving them in the process of not just education but in treatment development. Can you talk about how we could go about including patient perspectives and their lived experiences better in development of new drugs and where we go from there?
Yeah, so thanks, Michelle. It's been very humbling to actually be a part of this morning, and I'm grateful for the opportunity. Jagat, thank you for inviting me. Jagat and I go back a very long way, and I'm delighted that he's taking on the goal that he's ever had, which is cardiovascular health for everyone with the World Heart Federation. I've been reflecting on many things. Prabhakar, the idea that patients are people who live with long-term conditions, and our goal seems to be that the only long-term condition we want is health, and since that's not possible, perhaps life. But I think to that end, I'm reminded of the fact that, and what we have learned, certainly at Novartis, I've been there now for the last 23 years, that the only way to actually include the patient perspective is by including the patient perspective.
Novel.
And
Let's ask the patient.
And the most important thing I learned, having trained as a physician myself and practiced for many years, that any assumptions that you have through a long time of training that makes you believe that you know what they think is absolutely not true. And so what we do as a part of when we think about developing new interventions, it was also very interesting to recognize that most of the morning has actually never mentioned the fact that we actually use treatments to treat some of these conditions, which I recognize are not always accessible, and we do our part, and Lutz Hegemann, my colleague who looks after global health, is here, and we'll talk some more about our part to play. We talk about reimagining medicine together with everyone, and very humbly playing our part, which is to make some solutions available that enable the interaction between those that actually care for the patients, help them do it better. But to that end, in developing it, what we have now landed on is the fact that the group that in our organization we call patient engagement, and I always ask the question, engagement for the purpose of what, is actually included as part of my development organization. We think of workflows that ensure that that patient perspective is actively brought in right from the time of a research team that's actually thinking about what are the attributes or what are the current unmet needs or the experience of patients with currently available treatments, not based on what we thought is the most important. You're never compromising on the importance of the science or the target, but then thinking about what is it that's going to matter. So for example, if I took a different example, if it was going to be for years people thought, well, if it's a breast cancer drug, who cares if you need to do an ECG to assess if a QT prolongation is expected. Well, it turns out that that becomes a big hassle for people actually wanting to not do it, get on a drug sometimes, and if people had known it, they would have selected out a molecule that was least likely to do so. So that's at the earliest stage. When we're designing a protocol, no protocol is designed without it being reviewed by actual patients who are going to participate in the trial. The profile, we call it a target product profile, which is what's going to make this medicine attractive for patients to take, for physicians to prescribe. Those attributes are being described by patients actually being a part of that interaction at different stages. We do it both with individual patients, but also those that represent large patient associations, so that it's not the opinion of an individual, but it's a systematically collected view and perspective on an ongoing basis of a group of people who live with that disease. We also recognize that nobody has only one disease. And therefore, by definition, when that perspective comes in, if you're going to propose a solution that's going to interfere with something else, or on the flip side, if you could have an intervention that could potentially impact more than one comorbidity, well, then that's the one to prioritize. So all the way through, people are involved. And I'll just end by saying one final thing, which is that at the end of it all, there's something about humans that doesn't respond too well to being afraid of something that's going to happen sometime in the future. And that's typically about 5 minutes in my view, at least in my case. So I'm very embarrassed that I've been trying to control salt intake for 20 years too, still hasn't worked.
Bruce has a solution for you.
I know, I figured out, I made a note, I'm doing it. Jagat's been encouraging things. But I want to end by saying that we recognize that there's something about human behavior that we don't like to take things every day, multiple things like pills. And so we said, can we intervene with something that takes away the concern for having to adhere. And wouldn't it be great if you could address a risk factor by something that you can administer twice a year? And that only becomes possible because science advances to the point where you can be highly specific with an siRNA that allows it to happen. And we'll talk about it. But I think to come back to it, Michelle, the answer is by just being relentlessly committed to making sure that you actually have that voice at every decision place that matters. And you can't assume it, you can't predict it, you have to just secure it. And I think it's a good call out when you said, well, there is no patient on this panel.
I think it's important. I think it's very important to include their perspective, and I think it's valuable that you include them from the very front end of research. They can't just be the end user of the treatment. They need to be involved in the process. So I commend you and Novartis for that. We are exceptionally close on time, but I have one final question for each panelist, so you get like 12 seconds each to answer it so we can still finish on time. So the last message here, the last question is, will each of you share one key takeaway or one message, right? When we think about why we're here at the summit, why we have this opportunity, is to give some advice to policymakers. What is the one key takeaway? What is the one key message we want them to remember as it comes to addressing multimorbidity? And Professor Doviraj, I'll let you start on the end, and we can go down very briefly and hopefully end up with some really concise reminders for our policy friends around the corner.
So it's a difficult task, but let me attempt. I think identification of the problem, that multimorbidity or multiple long-term conditions, is the biggest bugbear in terms of improving quality of life as well as living long. And that should be ingrained into the policymakers arena. But I will end with a quote actually by author called Alvin Toffler, and I read his book called Future Shock in 1975 or 1980. And he said, the most successful man, obviously nobody paid attention to women then, the most successful man of the 20th century is one who learns, unlearns, and relearns. So I think there's a message there for all of us, be it the health system, be it health promotion, be it rehabilitation. There are a lot of things that we have to unlearn.
All right, Jose, you get 10 seconds.
Yeah. For me, the big question where you are talking about patient is, do a patients or the patient you are have access to care or not? And please, can you share some experience, some your own experience for improving the access to health system that is needed? And it's needed to talk not only theoretically about the cardiovascular risk, it's needed to share local experience because we can learn if each other. So it's needed to share success, local initiatives for improving the access and the care in cardiovascular medicine.
Very good, showing the best practices. Rick?
Policymakers respond to finances. Prevention is cheaper than treatment.
Excellent point. Taskim?
Scale simple, proven interventions.
Gemma?
Coronary artery disease is going to kill the most number of these patients, and actually personalising the approach to preventing the heart attack by including detection of disease needs a scalable and implementable approach across all of the low and middle income countries.
Excellent. Bruce?
You know what I'm going to say. So.
Change your salt.
Yeah, switch your salt supply
your
to
salt.
potassium-enriched salt. There you go.
All right, the final word to you.
Keep your say-do ratio low.
Your say-do ratio. I like that one. Fantastic. Well, thank you. Please join me in thanking our panel.